presentations, award presentations. We move on to our next leg of CME. So this 1 hour is part of the CME activity, and there could have been no better speaker than we have for this afternoon, Dr. Nageshwara Reddy. For few people who may not know, he is a renowned gastroenterologist and chairman of AAPI hospitals, which is one of the largest GI hospital chains in the world, and he is holding a distinct title of holding 3 Padma Awards. Actually, the only Indian doctor to hold 3 Padma Awards in India. So he received the second highest civilian honor, Padma Vibhushan, this year by the President of India. So please give a round of applause for Dr. Nageshwara Reddy.
So he got his Padma Shri Award in 2002, Padma Bhushan in 2016, and now Padma Vibhushan. And obviously this historic achievement highlights his significant contributions to the world of gastroenterology and his pioneering work in therapeutic endoscopy. He revolutionized digestive healthcare in India and beyond, known for pioneering advanced endoscopic procedures, launching India's first mobile endoscopy units, establishing AIG hospitals, and this is one of the Asia's largest referral centers for therapeutic endoscopy. And above all, the more important thing is promoting compassionate patient care. He emphasizes the importance of treating patients with dignity and empathy, and Dr. Reddy's dedication to the healthcare has earned him multiple awards, accolades. He's co-authored, peer-reviewed hundreds of articles in multiple journals, and he's bridged the rural-urban healthcare divide and has pretty much brought India to the map of World GI Endoscopy Service, and he was also the chairman of the World Endoscopy Organization Research Committee. So I could pretty much spend another hour just talking about his achievements, so why not just bring the person, the man of the hour, Dr. Nageshwara Reddy, please.
Thank you for that very kind introduction. I'd like to thank the AAPI Association for this invitation. In fact, this is the first AAPI I'm attending, and also the first time that I felt like a bridegroom when they had this music and the Bhangra dance going on. So it's a little different from what happens. So this was a very lively occasion, and I think to see so many friends here back, I keep meeting them sometimes in India, sometimes here. So it's a great occasion, and I'd like to thank AAPI again for giving me this opportunity. Can I have my slides? I'm a gastroenterologist, and in the last few years, I know that only some of you are gastroenterologists here, so I'll be very generic in my talk. In the last few years, one of the important fields of medicine which has dramatically made a difference in people's life because of therapies that are being developed is in gastroenterology. In fact, it's overtaken even cardiology. Gastroenterology therapies have come in form of many medical therapies, the biologics which have come, the small molecules which have come for IBD, for example, a lot of new molecules that are coming for non-alcoholic fatty liver disease. All these are making a huge impact not only in the therapeutics of gastroenterology, but in people's life. And now, of course, GLP-1 receptor agonists. All these, I think, are a major advance. But something which has really made a difference in gastroenterology, where 30 to 40% of people with gastrointestinal diseases have some sort of procedure done on them, is GI endoscopy. And my, of course, area of specialty is GI endoscopy. I come from an institute called the Asian Institute of Gastroenterology, but it's become multi-speciality, so we call it the AAG now. The AAG, to give you a background, is now we have 3 hospitals. The largest one is in Gachibowli, is about 1,000 beds. Predominantly 70% gastroenterology, but we have cardiology, about 30 other specialties. We also have another hospital in the city, 2 other hospitals in the city. So we have about 30 endoscopy rooms. We do on average 700 endoscopic procedures a day, many of them therapeutic in nature. We also do a lot of course, GI surgeries. We have a staff in gastroenterology of nearing 100 consultants, and we have about 50 fellows. So it's a large department. Considering that the population of India is about 1.45 billion, I think this is what we need in our country. Over the last 40 years, I had this journey in gastroenterology, in endoscopy therapies, and again, without going too much into the specifics, I'll just give you a very brief overview of what is happening in endoscopy. And some of these terms for the non-gastroenterologists will look quite new. For example, third space endoscopy, I'll explain to you what it is. We used to do what is called ERCP, or endoscopic retrograde cholangiopancreatography. Is changing now to doing endoscopic ultrasound guided therapies. There is something called functional endoscopy and artificial intelligence. All these are part of these new developments that are occurring. Now let me start with third space. What is third space? The first space in the gastrointestinal tract is the lumen of the gastrointestinal tract. For many years, since 1960s, when endoscopy came in, as gastroenterologists, we are actually going into the lumen, removing polyps, diagnosing early cancers, and so on. The second space is the peritoneal space, where the surgeons usually have the domain, laparoscopy, open surgery, and all. The third space is the tiny space between the gastric mucosa, the gastrointestinal tract mucosa, and the muscularis propria. It is predominantly the submucosal space. So all of you may be wondering, what can we do in this small space that has changed the whole dynamics of treating many patients with GI diseases? A lot of things can be done, and in fact, the first person who opened the eyes to this is an Indian gastroenterologist. Some of you may know him, Dr. Pankaj Parisha, initially in Galveston, then in Johns Hopkins, Stanford, and now at the Mayo Clinic in Arizona. He was the one who showed that in an animal model, you can go into this third space, cut the muscle endoscopically without opening the patient, and cure the problem for achalasia cardia, which can be a major problem in clinical practice. So based on these studies in 2010, a Japanese endoscopist, who probably will get the next Nobel Prize for doing this, created what is called POEM, peroral endoscopic myotomy. This is for patients having esophageal achalasia cardia. Without the need for Heller's open surgery, which has so many complications, he would go endoscopically, and then we can actually cut the muzzle layer and then open up the lower esophageal sphincter. He did the first case in 2008, and subsequently actually he visited the AIG, and we gathered the technique from him, and now AIG has the world's largest series of over 20,000 cases where this has been done very successfully. Patients the surgery is done, endoscopy is done in the morning, and the patients are discharged in the evening. Just compare with what happened earlier on. Patients would come in, go for surgery, 1 week later get discharged. So a major revolution that has occurred. Similarly, in patients with gastroparesis, diabetic and so on, in recurrent vomitings, no therapies for this. We do what is called the G-POEM, an extension of this. Through the endoscope, we cut the pyloric muscle, and then this again is very beneficial for most of the patients. So we have now a new techniques that in endoscopy are called POEMs, the E-POEM for achalasia cardia, refractory gastroparesis, the G-POEM, and so on. In fact, gastroenterologists like acronyms, so they sort of label it so it becomes easy for the procedure to be propagated. So for many years, we are removing tumors from the surface of the mucosa in the stomach, colon, called ESD, endoscopic submucosal dissection. But now, this has radically changed. Many of the diseases that were surgeons were operating on, like full thickness tumors, can now be removed endoscopically without the need for surgery. In fact, we have what is called EFTR, endoscopic full thickness dissection. Just imagine that you have a tumor in jejunum, ileum, wherever it is, and then we can go in endoscopically without the need for surgery. We can remove these tumors, and this full thickness dissection are being done very commonly in many centers all over the world. Again, we have one of the largest experience here. And the reason why this therapies became possible was that we developed a technique to close the openings. Few years back, 5 years back, gastroenterologists didn't have this technique or technology where if there's a hole in the stomach or colon, if you're doing a procedure, we would immediately send it off to the surgeon to remove and to close that. But now a lot of instrumentation has occurred with which these openings can be completely closed. And one of the technique is being shown in a video here. Even for a non-gastrointestinal endoscopy, you can very clearly see how a large opening like this, we actually suck back, and then we have a clip called the Ovesco clip which is released, and this large opening is completely sealed off. You can see how it's sealed off. So this is a common technique. Similarly, a much larger opening, this is a tumor in the duodenum. We are doing what is called the ESD. After we do this tumor, there's a huge hole in the duodenum. Can't imagine a few years back that this was being treated by an endoscopist, but now we have a technique called the King's closure, where putting a loop, we can close it within 3 to 4 minutes very easily without the need for the patient going for surgery. I think this is a major advance that has occurred in gastrointestinal endoscopy, the ability for gastrointestinal physicians, not surgeons, physicians, to close these large openings so there's no need for surgery, and you can see how securely this is closed. In fact, we're now getting something which is much more exciting. This is actually a stapling device. Usually surgeons use it, but now through the endoscope, if there's an opening, we just put a zipper like this and clip zipping, that's all. Just takes a few minutes to close large openings. So I think this is going to revolutionize many gastro. This was in the year 2003, 25 years back. This was a patient who came to me with extensive anterior wall burns. Me and my colleague G.V. Rao did what at that time was called the Notes procedure. Because we couldn't go in through the abdominal wall, we put a scope through the mouth, made an opening in the stomach. This was 25 years back. Went in and took out this very abnormal appendix through the mouth. You can see we're getting this appendix out through the mouth. So this was the first transluminal surgery ever done. It was called the Notes surgery. In fact, at that point of time, the sages, the American Society of Surgical Gastroenterology accepted that this could be done, and this has been a harbinger now for many other procedures in third space like this which is coming up. So now, both in India and China, we are now revolutionizing this new technique of doing transluminal surgeries. You can see gallbladders being removed, you can see appendices being removed, we can do major surgeries just going through the lumen of the stomach, the colon or the small intestine. So this transluminal surgeries is going to be the future of what endoscopies are going to do without the need for surgeries. And this is an example of colon cancer with secondaries in the lymph nodes which are removed endoscopically using this technique that we first described many years back. Of course, these advances are going to take time in the United States because of several reasons. The defensive medicine you have here, there's so much restrictions that you're going to have here, so it's going to take time. But hopefully they'll be recognized that these are techniques which are going to reduce the need for open surgery, which are going to make the whole technique much cheaper for the patient. And once that recognition comes, I think they'll be very rapidly introduced into United States also. So this third space, see what has been done with third space. Dramatic revolution. We can remove mucosal lesions, we can actually put in devices, we can take muscle biopsies, and what we are now doing also in third space is taking out islet cell from patients, from say islets from cadaver, and then we're putting into third space in islet bags in patients so that their diabetes can be adequately controlled using these techniques. We come to the second area where there's been, again, dramatic improvements, and this is an area called endoscopic ultrasound. 1989, it was a procedure which just came in 1989, and you can see on the TV screen there, the black and white screen, a very grainy picture. But over the last 20 years, there's been a dramatic increase in technology in this area. Of course, many companies have contributed to that, so that now it's becoming the main method of how we are treating many indications. For example, peripancreatic fluid collections is being done by this, but more dramatic is endoscopic GJ. We have now stopped doing surgical gastrojejunostomy in our institute. It is done endoscopically. You can see here it's a very simple technique in patients who come with a need for gastrojejunostomy. We use endoscopic ultrasound to make a connection between the stomach and the jejunum and put in a permanent stent here. And this is sufficient. Patient comes in the morning, gets a endoscopic gastrojejunostomy done, goes back in the evening. Again, totally revolutionizing the way how we treat outlet obstructions. Instead of going for open surgery, they go for this. And of course, similarly in patients with gastric varices, which is to be a problem treating them, we now use this endoscopic ultrasound technique to inject glue and coils. And now what we're doing is we're replacing radiologists. Radiologists commonly do a procedure called TIPS to bypass or to patients who have portal hypertension, have recurrent bleeds. TIPS is a procedure of choice. But now endoscopically, same technique can be done much more simply without the need for any percutaneous injections. So this is going to replace. So a whole new field of endoscopy is developing called endohepatology in patients with hepatic problems. Now we do a liver biopsy through endoscopy, we do TIPS through endoscopy, we do measurement of portal pressure through endoscopy, and tumors like hepatocellular carcinomas can now be treated very effectively using microwave or RFA through the endoscope itself without the need for percutaneous. One of the other things that has happened a few years now is that in patients who have advanced cholangiocarcinoma, for example, or advanced tumors, we should just put in a stent and say, okay, you're going to live for 6 months, just leave it alone. So as endoscopies, we started thinking, can we do better? Can we improve this patient's quality of life? Can we prolong survival? So we started doing, improving this palliation by doing a technique called radiofrequency ablation. Very simple technique which is done through the endoscope. And you can see through this radiofrequency ablation, initially when we started doing, we were surprised. Patients were living very long. Many of our patients with cholangiocarcinoma are now living for 5 years, 6 years, some of them longer. Wondering what happens. Just destruction locally of the tumor, how can it prolong life? And then we find of course, there's a lot of science behind this. I don't want to go into that, but we find that when you do RFA, a lot of cytokines are released. There's immunomodulation of the tissues, and even sometimes secondary deposits in the liver are destroyed by immunotherapy, immunological cells in the body once we do RFA. So now all patients with cholangiocarcinoma, for example, or pancreatic cancers, which cannot be operated on and removed, are now treated with a combination of endoscopic palliation and radiofrequency ablation with very effective results. The lifespan is doubled. Similarly, another instrument, very interesting instrument, is called the scope in scope. So through our regular scope, we can introduce another baby scope. Example is a cholangioscope. We can go in through this, go into the bile ducts, and you can see very clearly in the bile duct we can visualize. So earlier on, we used to depend on X-ray, inject dye into the bile duct or the pancreatic duct and see what is the X-ray picture. But now we go directly inside. So this is called ductoscopy, a new thing developing in gastroenterology, ductoscopy. With these very thin endoscopes, again, a lot of this technology is coming from China. Some of it is starting in India also, where they started to develop endoscopes which are very, very thin, just like a small thread. And with this endoscope, you can go very deep into the liver, see different parts, and do different procedures. And now we are starting to do ERCP with this ductoscope without the need for for X-rays. So we put this ductoscope inside, visualize the stone, remove the stones at the same time without the need for radiation. And of course, when fluoroscopy is not there, it's helpful not only for the patient, but also for the doctors, because we now know that there's definitely certain effects of radiation. And we're now getting what is called the intelligent cholangioscope. We actually have an intelligent chip attached to the tip of the endoscope, the artificial intelligence. And as soon as you go in, the cholangioscope tells us you're dealing with malignancy or not. Very simple. You don't have to take biopsies and all that. It becomes extremely simple. So this is something that is coming up also. Now coming to another interesting area, luminal endoscopy, and this is very interesting. In patients who have diabetes, this is a therapy that's coming. Look forward for this, even for all physicians. It's called duodenal mucosal resurfacing procedure. We destroy the duodenal mucosa from second, third, fourth part of the duodenum. The concept is this. The concept is that for all these years, we are thinking that the pancreas with insulin secretion was controlling the metabolic process of the body. That is wrong, totally wrong. The metabolic control of the body lies in the second, third and fourth part of the duodenum. This is nature's mechanism, because the first part of the body that comes into touch after we take food is the duodenum. So nature has put all the control in the duodenum. The brakes are in the duodenum, the accelerator in the duodenum. The pancreas is only a side effect. And unfortunately, for so many years, till about 5 or 6 years, our concentration, pancreas, insulin, and so on. But now we know that there are a lot of incretins, anti-incretins, GLP-1 agonists, all being secreted from the duodenum. So as endoscopists, we have the ability to manipulate, to control the duodenum, to destroy the mucosa. So what happens is that with the Western diets, and unfortunately it's happening in India also, many of us now have a duodenum which is packed with neuroendocrine cells secreting anti-incretins. If you destroy this neural mucosa, get back the normal mucosa, you get back a normal metabolic control, and this is the base of therapy. Huge amount of evidence. Again, I don't want to go into all this, and when we see that when we burn the duodenal mucosa, within 3 months, the mucosa becomes totally normal. But what happens is this normal mucosa does not contain the abnormal metabolic resistant cells that are there. It becomes totally metabolic neutral. And now we have a new device for this called the Reset electroporation device. We are now working with it in our institute. A lot of animal model studies have been. This is a very nice device which a cardiologist also use for electroporation. So we put this into the duodenum, into the second, third, fourth part of the duodenum. This device opens up and produces electroporation. That is, doesn't burn the tissue. It just produces holes in the cells there. See that holes? So the whole mucosa dies completely. The new mucosa which is regenerated does not contain this abnormal endocrine cells. And this is the technique of electroporation which we borrowed basically from the cardiologist, but we're using it now quite adequately. And see what happens. This is very, very interesting. We now have data. This is an example of a patient who was 100% of these patients were requiring insulin for very severe diabetes, some of them requiring very high dose. After we did duodenal mucosal resurfacing, by 12 months time, only 14% of the patients actually required insulin. 86% of the patients were insulin free, totally free. And look at this, what happens. This was the patient with fatty liver. Normal fat in the liver is less than 5%. But this patient had 23% fatty liver. 6 months later after the procedure and 12 months later it came back to normal, 2.8%. So ladies and gentlemen, this therapy of duodenal mucosal resurfacing is going to dramatically alter, not only for gastroenterologists, but for all physicians, whichever specialty are practicing, is going to alter how we treat our patients. We now have a very effective method, other than drugs, for reversing type 2 diabetes, for reversing fatty liver disease, and of course, cardiometabolic problems that come with that. So this is going to be a revolution. So you see, you find that every part of the metabolic indices have improved after you do duodenal mucosal resurfacing, and watch out for these procedures as they come. Of course, the other thing that we're now doing is in patients, you know that many of your patients, again, whatever specialty you practice, are on PPIs for long term, 10 years, 15 years, heartburn, they keep popping up these pills, and which we know is not the right thing to do. So we have now developed a new device called the GERDEX device, which is done endoscopically, very easy device where through the endoscope, we do a plication. We actually put small plicators and close the G junction to appropriate size so that reflux doesn't occur. And we just published this very large paper in the British Journal of Gastroenterology where we showed that using this improve all these patients the quality of life, but more importantly, 70% of the patients after this procedure are off PPIs. No more PPIs. Of course, the PPI industry is not very happy, but this is something that's going to, again, be a common methodology of treatment. So we come to another area. This is functional endoscopy. So majority of the gastrointestinal disease gastroenterologists know are because of no organic disease that we actually identify, but so-called functional disease, irritable bowel syndrome, non-ulcer dyspepsia, and so on. We never had an accurate method of diagnosing this. It used to be a diagnosis of exclusion. Rule out all the organic problems, then you have this. But we now have endoscopes which have electrical impedance, endoscopes we can smell, endoscopes which have sound pressure can be recorded. All these are coming in so that functional disease can now be diagnosed actually very accurately. And this is an example of a functional endoscopy using a system called EPSIS, which we along with a group in Japan developed, which are now starting to use to make a positive diagnosis of functional bowel disease. And finally, of course, artificial intelligence everywhere is there, and I think is being incorporated in endoscopy. These are the three major areas where Western endoscopists have been using artificial intelligence in better detection of colonic polyps, in early detection and biopsy of Barrett's, and of course in early gastric cancers. But we believe that it is a larger role. I'll come to some of that later in the keynote today in the evening, where in clinical care, documentation, quality assessment, everywhere AI is going to come and play a role in endoscopy. And a new branch of endoscopy has come. This is called the regenerative endoscopy. As endoscopists, we are always cutting things, throwing away things, closing things and so on. But we never used to regenerate. And regenerative, of course, is the ultimate thing that a physician can do in medicine. And now endoscopies are starting to do this. This is a study we are doing along with a group of Italian physicians where you can see this very clearly. This is a patient who had surgery done, and even for the non-gastroenterology, you can see the leak here. This leak from the esophagogastric junction didn't close in spite of all types of endoscopic therapies. What we did was we took from this patient's thigh, we took the fat from there, and we subjected to this fat to a series of processes, and within 15 minutes we got from the fat a very special layer. This is a layer of fat which contains stromal cells, mesenchymal stem cells, some angiogenetic factors, we still don't know which, and we injected this into this patient. See the large opening here? We injected this inside, and within 4 weeks' time, totally closed, completely closed. This regenerative medicine where gastroenterologists are giving the head on is now going to be applied to other specialties, but there are in our body, not only in the bone marrow, but in the adipose tissue everywhere, certain amount of very special cells which have the ability to go to any part of the body which is injured, regenerate there, and get back a normal tissue there. And this is something that we are now utilizing anywhere. Fistulas, gastrocolic fistulas, rectovaginal fistulas, esophageal fistulas, all the fistulas can be now closed very easily using this technique of regenerative medicine. And now robotics and endoscopy. This is a gastric samurai. And you see gastric samurais are experts. He can do this, and this is robotic and simulated. I can't do the same procedure, same way, consistently hundreds of times, whereas a robot can do it just like a gastric samurai. And that's the reason why robots are going to come into medicine. And this is the first human robotic technique that we described from AIG and the Singapore. This is very long back, almost now 10 years, where what we did was we used this robotics, two small hands attached to the tip of the robot, where we could, you can see these two small hands we attach, and watching on a machine, watching on the screen there, we can do robotic surgery and remove. There's just like the Da Vinci system of the surgeons, we can use this, and slowly they are now coming into picture, more and more robotic endoscopies. A combination of robotic endoscopies and artificial intelligence is becoming something that is going to take over in future. Of course, disposable endoscopes are used quite a lot here. This is because there was this infection problems. It's picking up slowly. One of the problems with disposable endoscopes is environmental, that they are now putting a lot of carbon problems. And this was area of interest for us. If you actually look at the carbon footprint and how much we are contributing as a health industry, you'll be surprised. We are the third largest contributors to carbon footprint in the world. Third largest after transport, aviation, and all those contamination fluid, health industry. And in health industry, it's first emergency medicine, surgical ICUs, and thirdly endoscopy, which is contributing to the carbon. And this has become one of the problems. The governmental agencies start looking at, should we, because there are a variety of ways how carbon footprint is created by endoscopy. So should we stop doing endoscopies and go to something else? This is a question that's often asked. So what we did was, using a variety of techniques, we produced net zero carbon endoscopy units. You can do that by a variety of techniques. Again, I don't want to go net zero carbon units. Yet we are contributing still, after putting a net zero carbon endoscopy unit, we are producing still a high carbon footprint. And when we looked at this in the literature and carefully analyzed it, and this is the paper we just published in the British Journal of Gastroenterology, where we showed the cause of carbon footprint for procedures in hospitals is not because of the procedure, but because of patients traveling to the hospital. In India, for example, for us, patients come from thousands of miles, from Assam, Delhi, Chennai. You can't stop that. This is the cause of carbon footprint, not the procedures itself. The only answer, in fact, we gave a white paper to the government. The only answer for this is establish more centers everywhere so the travel comes down. And that's the way to actually conquer the carbon footprint, and not by decreasing procedures, are very essential for the patients. So, ladies and gentlemen, you can see from what I showed you briefly, overview, that endoscopy is now a very disruptive technology. It is very difficult now to distinguish surgeons from physicians. Very aggressive endoscopy, physicians are doing what surgeons were doing some time back. And in fact, now surgeons are coming back to learn endoscopy and start doing that. We have a training program for the American Surgeons Association, because the American gastroenterology physicians refuse to train them. So the surgeons of US asked us whether they could do that, so we have a program. So they're coming back now to endoscopy. So this disruptive technology has now created a new specialty of therapeutic endoscopy, which is breaking barriers. And what is going to happen in future? This is a cartoon that we created 15 years back. This is from one of my friend, Guido Costa Magna, likes to watch football matches. It's the World Cup football going on, Germany versus Italy. And he's watching this match. Then suddenly one of his patients has severe abdominal pain. So she takes a pill in the house. He can't come to the hospital, he's watching the match, very important. So she takes a pill, and this pill has got an endoscopic ultrasound incorporated in it. So the pill takes the pictures, and through broadband sends it to the Guido house, in the TV screen. He's still watching the match, and then he gets a small thing on the screen saying he's got gallstone pancreatitis diagnosis. Now, gallstone pancreatitis is a medical emergency. He's supposed to rush to the hospital, but again, the football match more important. So he puts another pill inside, and a small robot comes out. This robot actually goes into the papilla, that's the papilla of Vater, opens it up with laser, goes into the common bile duct where the stone is there causing the problem. And this is the common bile duct. The robot is seeing the large stone there causing this pancreatitis, and then has a unique way of getting the stone out. Using a parachute comes out. So this stone is now out using this technique. This technology is actually available. The NASA is using it. He is very happy. The reason he is happy is that he not only didn't miss the match, the last important goal, he could see that was goal, that has made a change. So this technology, ladies and gentlemen, is actually available. NASA is using robots in Mars to get out rocks and come and analyze it here. The reason why it's been not translated into medicine is because of the commercial aspects. It can be done, and hopefully done in the future. Based on this, actually, when we made this video, a group in Stanford saw this, and now they created what is called the PillBot. PillBot is the same type of camera that I'm holding now here. You can see how we are controlling it from outside. This is a space scientist at Stanford along with Dr. Vivek Kumbari from Mayo Clinic together created this one, and we did this is the first clinical testing we did at AIG. And you can see we are maneuvering this from outside using a keyboard. It becomes very easy. And in future, we are starting a large clinical trial of using these robotic pills end of the year, and hopefully some of which I showed you as a cartoon will become a reality. And before I want to acknowledge these pioneers of 1970s who are responsible for all the development that occurred in the area of therapeutic endoscopy. But ladies and gentlemen, again I want to remind you that although we showed you all the advances in technology, all that can be done, all that's revolutionizing the medicine, This important painting gives you the importance of empathy, that endoscopy is not just science and art but empathy. Only when you have all these three up together, in spite of all the advances that have occurred, without this we can't do a complete patient treatment. We can't do what we should as doctors do, help our patients. Thank you very much.
Thanks, Dr. Reddy, for such an amazing futuristic talk. It just took us into a sci-fi world, which is actually happening right now in your arena out there. So at this time, I would like to open this up for any questions that anyone has. So I can't see very well from here with all the lights in there, but please raise your hand or just stand up. Okay.
Could you please elaborate on resurfacing of the pylorus control of diabetes?
Yeah. The question is regarding duodenal mucosal resurfacing for control of type 2 diabetes. So again, there's a huge science behind this. Because of time, I didn't go into this. As I said, the first thing, the realization came that the metabolic control of the body is in the duodenal mucosa, which contains a lot of neuroendocrine cells. These neuroendocrine cells are secreting anti-incretins, incretins in a balanced portion so that you have a euglycemia. But when we get used to a diet which contains low fiber, high carbs, refined carbs, over a period of times, more and more of anti-incretins develop. These anti-incretins are now secreting substances which results in insulin resistance. So if we look at type 2 diabetes, the main pathophysiology is a very high insulin resistance that they have. And of course, unfortunately, by giving insulin, we start increasing resistance and so on. We use drugs which try to decrease the insulin resistance, and now of course you have the GLP-1 receptor agonists which are there, which are useful. But to do it naturally, what we conceptualized is that if you can destroy the duodenal mucosa, which over a period of time has developed this large amount of anti-incretins, if you can actually destroy that, then what happens is that the insulin resistance comes down and body gets back to normal metabolic activities. Then the whole homeostasis becomes normal. So we started first with the animal work. The animal work was predominantly in rats and swine and then higher mammals, where could clearly see a lot of biochemical data has come from that, showing that you can actually decrease the insulin resistance, produce a HOMA-IR which is less than 3 by just destroying the duodenal mucosa. Then of course now human work has come in. The initial human work was done with a thermal balloon. We'd put this thermal balloon, burn the mucosa, and this was a very laborious process. But it was a proof of concept which showed that if you can destroy the second, third and fourth part of the duodenal mucosa, the new mucosa which comes in does not contain these neuroendocrine cells which produce the anti-incretins. Of course, patient has to again be very disciplined in terms of diet and so on. And then the HOMA-IR is coming down and the need for insulin goes up. Now the initial problem was using these devices, but now with this electroporation device which is very easy to use, this technique is going to now become very widespread. Predominantly it's more often used in Europe now because again there's a problem with FDA regulation and all that in US. But I think maybe in 3-4 years it will come into United States also and become one of the techniques of how diabetes is treated. There's a huge competition between the new class of drugs which are coming in, which are going to be used to decrease insulin resistance versus these endoscopic techniques. But my belief is ultimately it's going to be a combination therapy. We use a combination of endoscopic mucosal resurfacing and this newer class of GLP-1 agonists, which together are going to be the main technique of treating. So I think diabetic treatment is going to change dramatically. We're not going to treat it like what we do now.
Thank you. Thank you, sir. I'm Dr. Suresh Reddy, past president of AAPI. I remember you from 30 years ago when I was doing my MD radiology in Usmania and used to come to Usmania and give great lectures. We were odd then and we are again odd today. I have a couple of questions. One thing is like you are not only a great clinician, you are an innovator, you are a great educator and with great entrepreneurial skills. And you are amazing and you are great in all the 4 faculties. Any idea, any interest in creating an AIG in America, like American Institute of Gastroenterology?
So thank you, Suresh, for that compliment. But of course, I think it's more complex to create institutions in US, not only because of the many regulations, but also the financial aspects and so on. So to create AIG, maybe you can create the AIG, a new one which you have 1,000 beds for about 2,000 crores. But to create the same AIG in US would take $2 billion. So there have been many US investors who came and evaluated AIG and said, this is about $2 billion. So I think to start something at $2 billion is financially going to be extremely difficult. Whereas in India, it's much easier now because of course things are much, not only easier to create, but in addition to regulatory effect, even the equipment we get is much easier, cheaper. So I think creating institutions in US is extremely difficult. In fact, we had a tie-up with the Mayo Clinic for some years in the initial part. And the Mayo Clinic gastroenterologists and our gastroenterologists to compete. And ultimately landed that we started getting more papers than them in our institute. And also innovations are much easier in India because the regulatory atmosphere is better. Here you have too many blocks to innovate. Something like DMR and all would be extremely difficult here. It will take many years. So sometimes that can be frustrating. So I think there are difficulties of creating institutions like that here.
Thank you, sir. And please, everybody stand up and give a standing ovation.
I guess we have few more people who want to have some questions.
Yes, we have a question over.
I'm a general surgeon and I do endoscopy, and listening to you, gosh, I'm just saying, gosh, what is available? I can do any one of those things. Honest to God, this is magic.
Thank you.
I really think you should associate yourself with Tampa General Hospital, GI, and University of South Florida, USF.
Yeah. So we train, actually we have agreement with SAGES now. SAGES, yeah, they send at least 4 to 5 every candidate here, so we train them on this advanced procedure.
Then you better take me. Okay. No, seriously, I want to have one-to-one talk with you, sir.
Sure.
Okay, as soon as they finish, yeah. Thanks.
Thank you. Anand Gupta, back in 95, I did a month of fellowship, ERCP fellowship with you, if you remember.
Yeah.
Anyway, so my question had to do with the actual device for this duodenal mucosal surfacing.
Yeah.
Is it similar to Barex that we use here?
No. Barex is the RFA device.
Right.
So we did try Barex, but the problem with Barex was the duodenal wall is very thick.
Right.
So the potential chance of injury and perforation is high.
That's my next question.
Yeah, so that's the reason why we didn't go into RFA. But electroporation is very safe. The cardiologists use this for electrophysiology work.
Right.
So it's a technique which puts hole into the cells without actually burning the cells. Mm-hmm. So the cells undergo apoptosis and then gradually die. So this is a very safe technique, and that's why electroporation. There are other techniques that we're exploring, like using steam and so on, but currently I think electroporation is the best device. So Barex, the reason why we didn't want to go ahead with Barex is the potential chance of complication.
Is anybody doing trials in US right now? On this?
US, no, most of the trials have been outside. Again, this problem is regulatory.
Exactly.
US didn't want. In fact, the first thermal device, the concept was devised in US itself by an Indian cardiologist working in Boston, because he was doing cardiac. But unfortunately he didn't get regulatory approval in US, so he came outside US to do all these studies.
Thank you, sir.
Yeah, that's a great talk. I'm actually a surgeon, so I can understand where you are coming from.
I'm worried there are not too many surgeons here in the audience.
So it's a great and lot of new innovations, and as you said, the technology is out there.
Yeah.
It's all about the scaling up and making it available for general public. I know in India, most of the US companies comes there and do the initial research, but is there any effort from AIG, which is now big giant, in terms of developing actual scopes or actual industry there? Because anything that's manufactured in India will be cheaper and much quicker to come to the world.
Yeah, so that's a good point. In fact, we actually debated on this, and now we started a innovation center, startup center, which is open to anybody. Any surgeon or anybody or endoscopist gets an idea, he can, along with IIT, we started this innovation and startup center. We in fact do the initial funding for them. So somebody has got an idea, okay, I want to make this stent. He comes to this innovation startup center at AAG. He can devise the stent and all that. We have a large animal lab in the basement of the hospital where the animal work can be done. And if we think it's worthwhile, we then do the clinical trial part of it. We have a couple of patents based on that. There are many US companies which are coming to us to do their part, but we would, I think there's 2 or 3 issues in that. One is, even if you do this there, you have to, FDA now is very strict about doing clinical trials in US to approve it, otherwise they won't improve. The second thing is, although it's cheaper for them, for us, we are trying to encourage local industry, Indian entrepreneurs, Indian scientists to see if they can come up. And that's the reason why it's predominantly limited to that. The IITs have got phenomenal engineers with them. And of course, with these facilities that we provide them, with some very bright doctors coming together, we believe in the next 10 years, we can be an ecology in India which can be the center for, or rest of the parts of India also will become centers for innovation and directing future therapies in medicine. I think we're getting to that basically because now Indian economy is better, we're getting the centers because of IITs. And one of the fortunate things that's happening is that it is becoming more difficult for bright engineering students to come to US now with all the visa problems. So that is helping India now. They stay back and then they innovate and help us.
Yeah, no, I agree with all that. I mean, the main thing is if US companies are involved, it takes forever to scale up across the world.
Exactly. So US companies, other problem is when they see a technology which is conflicting with their technology, they come in and they suppress this technology. So that's another problem that occurs. So one has to be very careful. I think now India, China, Japan, to some extent Korea, South Korea, all of us have very good engineers and technologies and startups and upgrading should occur. Again, we have a large population groups, so you can do clinical studies very rapidly. And next few years, you'll see a lot of clinical studies coming from there.
Thank you.
Thank you, Dr. Reddy, for the excellent presentation. I'm Suresh Sachdeva, pediatrician. I have a specific question. I have a patient, 23-year-old, with a progressive, degenerative colonoparesis as well as the gastroparesis now progressively, and I think that intestines are going to get affected also over a period of time. Any of these neurostimulation will work?
Yeah, so we have experience with electrical stimulation of the gastric electrical stimulation and colonic. Unfortunately, once the neurons are destroyed, especially in the muscular layer, it is very difficult to create stimulation of this. So I think that's very unfortunate. What we'll have to actually look at, if we have the histopathology and electron microscopic study to see if it's a mitochondrial myopathy, where some new therapies are coming in. But unfortunately, I don't think we can help much.
Excellent. Thank you, sir.
First of all, as a old student of yours in Hyderabad, you have inspired many generations of physicians, young physicians, to become gastroenterologists. That is the reflection of, and we are still learning from you as students. That's highly commendable. My question is about, as obesity is a growing problem in India, I mean, what is being done in India in terms of endoscopy for obesity, like any innovative technologies being developed there?
Yeah. So, Nagaraj, thank you for the compliments first. And regarding obesity, I didn't go into endobariatrics because it's a separate specialty by itself. Endobariatrics, of course, is the routine endobariatrics like endoscopic sleeve, gastroplasty is something that's done routinely. In fact, again, our center, Dr. Rakesh is the leader for this. We are doing a lot of endobariatrics. But also, we are getting into some innovations where we have some new techniques based on the physiology. For example, we are now starting to do fundoablation, fundal part of the stomach, ablation of the mucosa using large APCs. A new type of APC catheter has come. With that, what happens in the ghrelin level comes down, the appetite comes down. So if you combine this along with a single endosuture, then these patients are dramatically losing their weight much better. We also devised a new sleeve for especially diabetes and obesity combination. We have a sleeve which we put in the duodenum, which goes across the duodenum into the jejunum. So when you eat food, it bypasses the duodenum, bypasses all these mechanisms. And within 6 months, they lose a lot of weight and the diabetic control also comes back. So a lot of new innovations. Again, because of time, I didn't want to go into this thing.
Thank you. And again, Dr. Reddy will be around, so if anyone wants to talk later on to him, and another round of applause for him. And
thank you, Dr. Reddy. So this talk I heard about 8 years ago in Mumbai when we did the Global Health Summit, and I always wanted you to really present this in AAPI. When I requested you, you're kind enough to present this. And such an amazing topic, such an amazing presentation. Thank you so much. And he's a Padma Vibhushan Awardee, and that's his second highest civil award given by Indian government. And we wish and pray that you get Bharat Ratna, because you totally deserve that. Because such a pioneer in GI, saving so many lives, making the quality of life better for so many patients. It's much better than giving it to a sports guy or a politician or something like that. So you truly deserve it, sir. Thank you so much for coming all the way. I really appreciate that.